Hello people, this is Dr. Muskaan this side, and today I'm going to discuss very interesting case. Here is 46-year-old male who has came to ER. He is security guard by occupation. He has chief complaints of vomiting and loose motion since evening. On arrival, ABCS was done, that is airway, breathing, circulation and sensorium. Airway was patent. There were no signs of airway obstruction. To your acknowledgement, what are the signs of airway obstruction? It is hoarseness, dysphagia, dyspnea, stridor, uncomfortable to breathe on lying or sitting, choking, or someone is holding his neck कि मेरे को सांस नहीं आ रहा. Okay, so on breathing assessment, respiratory rate was normal, it was 20 per minute, SpO2 was 98% on room air. On circulation assessment, pulse was 74 per minute and BP was 94 by 64, which shows that it is hypotension. Sensorium was alert, it was E3, V5, M6, that is 14 by 15. Eye opening was on sound. Verbal response was oriented, motor response, he obeyed the command. RBS was 136 mg per dl and temperature was 98.6 degree Fahrenheit. Patient on arrival was irritable, thirsty, there was sun-keen eyes, skin pinch goes back slowly. So here are some signs of some dehydration. Now HOPI, the patient was apparently alright since yesterday when he developed chief complaint of vomiting, which was non-projectile, contains food particles followed by water, followed by green color water at last, which is suggestive of bilious vomiting. It was associated with colicky pain in abdomen. There was no blood mixed with food particles, that is, we ruled out hematomasis here. There were 5 to 6 episodes of vomiting. Patient also presented with history of loose motions, which was watery in consistency and not mixed with blood. Negative history, there is no history of fever, epistaxis, ENT bleed, gum bleed, hematogasia, hematuria or melena. Past history, there were no comorbidities such as diabetes, hypertension, thyroid, epilepsy, TB or TB contact or any other comorbidities. Personal history, patient is vegetarian by diet, bladder habits are normal, bowel habit shows diarrhea, sleep is less than normal, addictions of tobacco chewing is present, there were no addictions of alcohol and smoking. On examination, decubitus was, the patient is lying comfortably on bed, oriented to time, place and person, he is cooperative by nature, there was no confusion or agitation present. Vitals, patient was hypotensive, it was 98 by 58, pulse rate, respiratory rate, SpO2, temperature all were normal, parallel was moderate, clubbing, icterus, cyanosis, lymphadenopathy, edema were absent. On systemic examination, CVS examination S1, S2 was present. Respiratory examination, there was decreased bilateral air entry, Krebs was present and bronchi was also present in the inframammary region and in the interscapular region. CNS examination, GCS was 15 by 15 at present. Bilateral pupil reaction was there. On abdominal examination, there was tenderness in the right upper quadrant due to the GB sludge, which was seen in ultrasound. Now, investigation picture of the patient. CBC shows patient is having anemia, thrombocytopenia, and RDWSD was increased. It was 88.4 FL, and RDWSD is your red cell distribution width, and if it is increased, it is suggestive of mainly iron deficiency anemia. हीमोग्लोबिन तो पहले से ही कम था, 6 था, तो इसलिए एनीमिया बोल दिया, बट RDW इंक्रीज है तो इट इज़ सजेस्टिव ऑफ आयरन डेफिशिएंसी एनीमिया. LFT picture shows 2.6 gram per dl of albumin, which shows hypoalbuminemia. KFT picture shows AKI, acute kidney injury. Why? Because there was increase in urea and creatinine levels, there was hyponatremia, hypokalemia and hypocalcemia. On stool examination, there was hanging drop for cholera present, and on stool routine microscopic examination, there was brownish loose stools, no blood, no pus and mucus was present. Procalcitonin levels were raised, normal lies between 0 to 0.5 nanogram per ml, but it was 7.98 nanogram per ml. Ferritin level was reduced, vitamin B12, 11 were increased, Iron profile, iron was reduced, TIBC was normal, transferrin was normal, and peripheral blood smear picture shows macrocytic anemia. Other tests such as dengue test, typhoid dengue DO NS1 antigen IgM IgG was negative, typhoid IgM was positive, and typhoid IgG was negative. Hepatitis B antigen HCV HIV1 and 2 were negative. ECG shows T wave flattening and presence of U waves, which is suggestive of hypokalemia. Chest X-ray shows right side pleural effusion, left side obstruction in the diaphragm, and there was bottle shaped heart. Ultrasound shows GB sludge and left side pleural effusion. ABG picture shows metabolic acidosis. When I have calculated anion gap, there was hagma. When I have calculated delta gap, there was acidosis because it was less than 6. Delta ratio shows 1.8, which shows uncomplicated hagma. When I have calculated GFR of patient with the help of the GFR calculator from the Google, it was 11 ml per minute because AKI was present, so I calculated it. So that shows me there is stage 5 kidney disease, and in the ICU itself the patient was on hemodialysis. Next, I have calculated Cockcroft-Gault formula, in which we see the creatinine clearance of the patient, which is calculated in ml per minute, which comes out to be 14.14 ml per minute, which is also suggestive of CKD stage 5, that is end stage renal failure, and the formula for CRCL is 140 minus age into body weight divided by serum creatinine into 72. Now, the urine input of the patient was 2521 ml per 24 hour, but output was only 50 ml per 24 hour, which was very less suggestive of uremia. Now, management of the patient. Injection Metrogel was given, which is the treatment for bacterial infections. Injection Ciplox was given, which was treatment for bacterial infection. Injection Pantop is given, which was PPI for GERD. Injection MCIT was given, which was treatment for vomiting. Enterogermina was given, which is probiotic treatment for diarrhea. Capsule Riododil is given, which is antidiarrheal medication. Injection calcium gluconate 10% was given, which was treatment for hypocalcemia. Electrolyte powder in 1 liter of water was given. So at last, what was the diagnosis of the patient? It was CKD stage 5, enterogastritis with some dehydration, metabolic acidosis, and megaloblastic anemia. So that's all. I really enjoyed learning on this case, and I hope after listening to the history of the patient, you have also enjoyed and you also learned some good points. That's all. Dr. Muskaan Bansal is signing off now.